Aging refers to a chemical process in which the bond between the organophosphate and acetylcholinesterase becomes progressively stronger and irreversible over time. You can think of this process like cement being applied between bricks. Initially, when the cement is still wet, the bricks are joined, but the bond is not fully set. So if you act quickly, you can still separate them. In the same way, early after organophosphate binds to acetylcholinesterase, Pralidoxime can break this bond and restore the enzyme. Now that we've understood direct-acting muscarinic agonist and reversible acetylcholinesterase inhibitors, let's move one step further. We now enter a much more dangerous category: indirect-acting acetylcholinesterase inhibitors that are irreversible. These are commonly known as organophosphates. These compounds were first developed in the early 20th century, mainly in Germany, during research on chemical warfare agents. Scientists were initially exploring highly toxic substances for military use, and this led to the discovery of powerful nerve agents like sarin. However, it was soon realized that in much lower concentrations, similar compounds could be extremely useful in agriculture. This gave rise to organophosphates like Parathion and Malathion, which became widely used as insecticides. Their major benefit in farming is their ability to effectively kill pests by disrupting their nervous system, thereby protecting crops and significantly improving agricultural yield. If we look at the important organophosphates, most of them are actually used as insecticides, such as Parathion, Malathion, isoflurofate, and Chlorpyrifos, which are commonly encountered in agricultural settings. In addition to these, there are highly toxic nerve agents like sarin, soman, and tabun, which were developed for chemical warfare and have no medical use. Now, among all these compounds, only one has a role in clinical practice, and that is ecothiopate. It is used topically in the eye for the treatment of glaucoma, where it increasing acetylcholine levels and improving aqueous humor outflow. However, due to its prolonged action and potential toxicity, its use today is quite limited. So in today's lecture, we will focus on organophosphate toxicity. What happens when these insecticides or pesticides are accidentally or intentionally ingested? We will try to understand how these compounds affect the body, what kind of symptoms they produce, and why this condition can become life-threatening if not treated in time. Organophosphates inhibit acetylcholinesterase in an irreversible manner. As we discussed earlier, the acetylcholinesterase enzyme has two important functional sites, an anionic site and an esteratic site. Reversible inhibitors usually interact with both of these sites through relatively weaker, non-covalent interactions, which is why their effect, although sometimes prolonged, can eventually subside as the enzyme becomes active again. However, organophosphates bind specifically to the esteratic site of the enzyme and form a strong covalent bond, leading to phosphorylation of acetylcholinesterase. This covalent attachment is highly stable, and as a result, the enzyme becomes inactivated for a prolonged period. Because of this, acetylcholine cannot be broken down and starts accumulating at synapses, leading to continuous stimulation of muscarinic and nicotinic receptors. Prolonged stimulation of muscarinic receptors by excess acetylcholine produces a wide range of parasympathetic effects throughout the body. In the eye, it causes miosis along with spasm of accommodation, leading to blurred vision. In the cardiovascular system, it results in bradycardia and sometimes hypotension due to reduced cardiac output. In the respiratory system, there is bronchoconstriction along with increased bronchial secretions, which can make breathing difficult. In the gastrointestinal tract, it leads to increased motility and secretions, causing abdominal cramps, diarrhea, nausea, and vomiting. Similarly, in exocrine glands, there is excessive secretion, resulting in salivation, lacrimation, and sweating. So, if a patient presents with acute toxicity of organophosphate compound, you will typically see a very characteristic clinical picture. The patient often has pinpoint pupils. In addition, there is a generalized increase in secretions, almost as if every gland in the body has been switched on. You will see profuse sweating, making the skin cold and clammy, along with excessive salivation that may lead to drooling. There is also increased lacrimation, so the patient may have watery eyes. Because of gastrointestinal and genitourinary overactivity, the patient may experience vomiting, diarrhea, abdominal cramps, and even involuntary urination, so their clothes may be soiled. On the respiratory side, bronchoconstriction combined with increased bronchial secretions can cause significant breathing difficulty and may even lead to respiratory distress. In the cardiovascular system, you will notice bradycardia and hypotension, resulting in a slow and weak pulse. In addition to muscarinic effects, excess acetylcholine also stimulates nicotinic receptors, particularly at the neuromuscular junction. As a result, the patient initially develops muscle twitching and fasciculations due to repeated stimulation of skeletal muscles. This may be followed by muscle cramps and weakness. However, because the stimulation is continuous, the receptors eventually become desensitized, leading to flaccid paralysis. This is especially dangerous when it involves the respiratory muscles, such as the diaphragm, which can result in respiratory failure. So overall, nicotinic effects progress from early stimulation, seen as twitching, to later paralysis, which is a critical and life-threatening complication in organophosphate poisoning. And also because of their lipid-soluble nature, many organophosphates can easily cross the blood-brain barrier and enter the central nervous system. As a result, excessive acetylcholine accumulates within the brain, leading to continuous stimulation of central cholinergic pathways. Initially, the patient may develop symptoms like anxiety, restlessness, confusion, and headache. As toxicity progresses, this can lead to agitation, delirium, and seizures. In more severe cases, there is depression of central respiratory centers, which can further worsen respiratory failure. Ultimately, the patient may develop coma. So, the organophosphate poisoning is a serious and potentially life-threatening condition involving both the peripheral and central nervous systems. So, the main aim of treatment in organophosphate poisoning is to rapidly reverse the life-threatening effects of excess acetylcholine. In simple terms, our goal is to reduce the overstimulation of cholinergic receptors. At the same time, we also try to reactivate this acetylcholinesterase if possible and prevent further exposure to the toxin. So overall treatment is focused on three key priorities. First, stabilizing the patient's airway, breathing, and circulation. Second, blocking the effects of accumulated acetylcholine. And third, restoring enzyme activity to stop ongoing toxicity. So, the treatment of organophosphate poisoning should always be approached in a stepwise and systematic manner. The very first thing you must do, even before you touch the patient, is ensure personal protection. You must wear gloves, gowns, and aprons because organophosphates are highly lipid soluble and can be absorbed through your own skin. Once you are protected, the immediate priority is decontamination. You must remove all of the patient's clothes and wash their skin thoroughly with soap and water. This is crucial because if you don't, the poison will continue to be absorbed through their skin, making your medical treatments much less effective. After this, the first priority is to stabilize the patient's airway, breathing, and circulation. If the patient has respiratory distress, give oxygen and be ready for intubation if required. Now let's talk about the first medication you'll give. In organophosphate poisoning, the patient is essentially drowning in their own secretions. They'll have massive bronchial secretions, bradycardia, and miosis. Your primary goal is to dry up those lungs. Therefore, atropine is the first-line drug you must give. The initial dose is typically 2 mg to 5 milligrams IV. Some protocols start with 1.8 milligrams or 3 milligrams, but 2 to 5 milligrams is a common standard. You should repeat this dose every 5 to 10 minutes until you achieve atropinization. Atropinization refers to the process of giving atropine in adequate and repeated doses until the signs of excessive muscarinic stimulation are effectively controlled. In other words, we keep administering atropine until the patient shows clear clinical improvement. You'll know you've reached this point when the lungs are clear on auscultation, the heart rate is above 80 beats per minute, and the systolic blood pressure is over 80 millimeters of mercury. Remember, we don't wait for the pupils to dilate. We focus on the lungs and the heart. Once you've started the atropinization process, you'll introduce the second medication, pralidoxime. While atropine only blocks the muscarinic receptors, pralidoxime actually works to unlock the acetylcholinesterase enzyme that the organophosphate has inhibited. The standard dose is 1 gram to 2 grams IV, administered slowly over 15 to 30 minutes. This is often followed by a continuous infusion of about 8 to 10 milligrams per kilogram per hour. It's most effective if given early, before aging of the enzyme toxin bond occurs, which occurs over time and varies with the compound. Some agents like Soman cause aging within minutes, while others may take hours to even up to 24 to 48 hours. Aging refers to a chemical process in which the bond between the organophosphate and acetylcholinesterase becomes progressively stronger and irreversible over time. You can think of this process like cement being applied between bricks. Initially, when the cement is still wet, the bricks are joined, but the bond is not fully set. So if you act quickly, you can still separate them. In the same way, early after organophosphate binds to acetylcholinesterase, pralidoxime can break this bond and restore the enzyme. However, as time passes, the cement begins to harden and set firmly. Once it has completely set, the bricks are permanently fixed together, and it becomes almost impossible to separate them without breaking the structure. This stage is what we call aging, when the bond between the organophosphate and the enzyme becomes so strong that pralidoxime can no longer reverse it. This is why early administration of pralidoxime is crucial in organophosphate poisoning. Regarding gastric lavage, this should only be performed if the patient has ingested the poison and arrives at the hospital within 1 to 2 hours of ingestion. If it's been longer than that, the risks often outweigh the benefits. When you do perform it, the position of the patient is absolutely critical to prevent aspiration pneumonia, which is a common cause of death in these cases. You must place the patient in the left lateral decubitus position, lying on their left side, with the head of the bed in the Trendelenburg position, head tilted down at about 20 degrees. If the patient is unconscious or has a depressed gag reflex, you must intubate them first to protect the airway before starting the lavage. Finally, don't forget the supportive care. Many of these patients will experience seizures or severe muscle fasciculations due to the overstimulation of nicotinic receptors. In such cases, benzodiazepines, specifically diazepam, are the drugs of choice. Throughout the entire process, you must maintain a clear airway, provide supplemental oxygen, and monitor the patient's vitals closely in an intensive care setting. By following these steps, decontaminate, atropinize, reactivate the enzyme, and protect the airway, you give your patient the best possible chance of recovery. We should avoid drugs that can further depress respiration, such as morphine. Morphine can slow down breathing and worsen respiratory failure, which can be dangerous in these patients. Similarly, drugs that prolong the QT interval should also be avoided when possible, because the patient may already have an unstable heart rhythm, and these drugs can increase the risk of serious arrhythmias. Now, after acute toxicity, let's briefly discuss what happens in chronic exposure to organophosphates. Chronic toxicity usually occurs due to repeated or continuous exposure to low levels of organophosphates, which is commonly seen in agricultural workers. Over time, these patients can develop a delayed neuropathy known as organophosphate-induced delayed neuropathy. This primarily affects the peripheral nerves, leading to muscle weakness, especially in the lower limbs, along with sensory disturbances like numbness or tingling and difficulty in walking. Importantly, this effect is not directly due to acetylcholinesterase inhibition, but is related to damage to nerve axons and myelin, producing a demyelination-like picture. Because organophosphates are lipid-soluble, they can enter nerve tissues and affect the myelin sheath, contributing to nerve damage over time.